fmQUICKIES. Today we'll be talking about hyperthyroidism. So what is it? Basically, it is a process where your body is producing a high amount of the thyroid hormone and secreting it all over your body. And definition of thyroid toxicosis is basically a state where your body is reacting to the high amount of thyroid hormone in your body and its action. It can happen when you are in a state of hyperthyroidism, inflammatory thyroiditis from infection, or if you are popping a bunch of synthroids. What can happen with thyroid toxicosis? You can suffer from complications including thyroid storm, where we'll talk about in a second here. And you can also suffer from cardiac, neurologic, and musculoskeletal symptoms, causing morbidity or even mortality. And you could possibly have bulging eyes if you are suffering from Graves' disease. So how does your typical patient present to the clinic? Usually they would be complaining of heart palpitations, tachycardia, problems with catching their breath. They may be complaining of a lot of weight loss, even despite a good appetite. These are people with additional thyroid hormones, so their metabolism is really high. These patients are the really fidgety patients that really can't stay still. They would be having a lot of hand tremors. They would be diaphoretic, and with so much going on, they would be complaining of fatigue as well. They would have a lot of anxiety and poor concentration, and the opposite of hypothyroidism, the cold intolerance, they would have heat intolerance. So how do you diagnose someone with hyperthyroidism? So if you find someone with the clinical symptoms that we talked about just earlier, you would do some blood tests. Unlike in hypothyroidism, where you would just get TSH, if you're suspecting anyone with hyperthyroidism, you would measure a TSH and a free T4. If the patient's TSH is normal, you can essentially exclude them from hyperthyroidism. Now, if their TSH was low, it would basically mean that they have hyperthyroidism. Now, if their TSH is low and you were smart enough to get a free T4, it would confirm that the patient is in a state of thyroid toxicosis. If the TSH is low and their free T4 is elevated, if their TSH is low but their free T4 is normal, they can possibly have subclinical hyperthyroidism, which means they are on the way to hyperthyroidism, but they're not full-blown yet. Now, the classic hyperthyroidism, Graves' disease, is diagnosed with the blood test that reveals hyperthyroidism, and you also find clinical findings like symmetrically enlarged thyroid gland, or the bulging eyes that we see in the textbooks. If you are unsure exactly what the etiology of the hyperthyroidism is, then you would send the patient for a thyroid scan. So what kind of information can you get from a thyroid scan? If the thyroid scan reveals that the glands diffusely have high uptake of the radial iodine, then it would suggest that the patient has Graves' disease. If they have a single or multiple foci of increased uptake, then they could either have a toxic adenoma or a multinodular goiter. If it is low or absent uptake, it would suggest they would have possibly a infectious etiology like thyroiditis, or a non-thyroidal source. Maybe they are popping synthroids like we mentioned earlier. Along the lines of low uptake, if they have a cold nodule, it would prompt evaluation for cancer. So here's some pictures of thyroid scans. So on the top left here, you can see right over here a cold nodule. So basically, it's a nodule with low uptake. This is concerning for cancer, so you would have to send a patient for a biopsy to rule out cancer. And in Graves' disease, you see how there's a symmetric uptake, high uptake of the material here. And in toxic multinodular, you can see how there's sparse areas, and then you have areas of high uptake. And over here, you have a hot nodule, so likely a toxic adenoma. And over here, you actually have a gland, one side of the gland where it's uptaking most of the material. So you have one gland that's overactive, half of the gland is overactive, and the other half is not active at all. And like we mentioned earlier, if it's an infectious etiology like thyroiditis, the gland would not be, would have lower uptake. So how do we manage hyperthyroidism? So the mainstay therapy is beta blockers. You would basically use it for symptomatic relief and for any symptoms that hyperthyroidism would cause. With thyroid storm, just take a minute really quickly here to talk about what a thyroid storm is. It's basically when your body has a lot of thyroid hormone and all your organs are responding to it. You have cardiovascular effects, neurovascular effects, CNS effects, and it's a really serious condition, and it actually causes deaths in the hospital. So you treat it with beta blockers, and you combine it with anti-thyroid medications, iodine, corticosteroids, and with the patient so metabolically driven, you want to cool them down. You want to give them volume resuscitations because they're most likely diaphoretic and they are vomiting and unable to keep PO intake. And with these patients, you want to make sure they are in the ICU so that you can monitor them more closely. So there's a little mnemonic here. It's called PCPS, or you can kind of PCPs when you think about primary cares. So P stands for propofol uracil. So this is the anti-thyroid medication. This is the first line for thyroid storms. And then you can use corticosteroids. It can help with patients with adrenal insufficiencies and prevent the conversion from T4 to T3, which is a lot more potent than T4s. Beta blockers like propranolol. Propranolol was chosen because it can actually help prevent the conversion of T4 to T3s peripherally as well. And S, this is kind of the oddball here. S stands for saturated solution of potassium iodide, SSKI for short. Oh, and one thing here, you would never want to give the iodide initially. You always want to make sure that they at least have the anti-thyroid medication first before giving them the iodide. And with other causes of etiology of hyperthyroidism, you kind of treat it based on the condition they have. So with Graves' disease, you give them anti-thyroid medication, radioactive iodine, and if those don't work, or if they have a really large goiter, you can consider using a thyroidectomy. For toxic multinodular goiter and toxic thyroid adenoma, you can give them the same similar management. You give them radioactive iodine and thyroidectomy in preference to anti-thyroid medication. And of note, for Graves' disease, you actually give them methimazole instead of propofol uracil in thyroid storm. And if it's an infectious etiology, then you would give them antibiotics to treat further infection and give them supportive symptomatic management with NSAIDs and consider corticosteroids. Well, thank you for tuning in.